Hello, I'm Tony DeMaria, bringing you the highlights of the February 19th issue of JACC. The role of mental stress in ischemic heart disease has always been controversial. And in the February 19th issue of JACC, we have a really interesting article from Duke that explores the role of mental stress in producing myocardial ischemia. Now, what's particularly notable about this manuscript is that these are patients with stable coronary artery disease who have not been shown to have myocardial ischemia on stress testing. So the investigators took these individuals and they subjected them to mental stress, arithmetic, etc., and then also compared this to exercise-induced myocardial ischemia using the usual criteria of ST segment elevation, regional wall motion abnormalities, etc. What they found was really very interesting. They report that over 40% of the patients manifested new myocardial ischemia in the face of mental stress in response to mental stress. Now, this was even greater than the number of patients who exhibited myocardial ischemia to exercise exertion. Even more interestingly, it turned out that those patients who were most susceptible to myocardial ischemia in response to mental stress were those who lived alone, who were unmarried, and particularly females in these situations. This has some interesting implications regarding Takotsubo disease, or so-called stress cardiomyopathy, which may in fact just be a much more severe, advanced, and prolonged ischemia in response to mental stress. So again, an important variable, one to keep in mind, even in patients who don't show myocardial ischemia with exercise-induced stress. The importance of angina as a risk stratifier in patients with coronary artery disease has been studied for many years with variable results. In this issue of JACC, we have a new study that deals with the relationship of angina and subsequent morbidity and mortality, or composite events, in patients with coronary artery disease from the Barry 2D trial. You'll remember that was a trial of patients with coronary artery disease who also had diabetes. And the investigators took those patients and divided them into a group that had typical angina, a group that had anginal equivalents, and then another group that had no angina reported at all. Now, remember, all of these patients had documentable ischemia with stress testing. What they found was really quite interesting. In fact, the presence of angina did not make much difference in terms of ultimate composite events, and there was no statistically significant difference in events between the patients with angina, anginal equivalents, or neither angina nor anginal equivalents. This goes to point out that patients with coronary artery disease, even when they're totally asymptomatic, are no different than those patients who have quite a bit of angina, and all of these patients should be treated identically. Just as attention has been focused on the necessity for very intensive control of blood pressure and blood glucose, so the question has been asked as to how strict rate control has to be in patients with permanent atrial fibrillation. Now, the RACE-2 trial, the rate control and permanent atrial fibrillation trial, addressed this question and showed evidence that strict rate control and lenient rate control were not statistically significantly different in outcome and events. However, analysis revealed that many of the patients in the strict rate control group actually were not controlled to the degree that was anticipated. And so the question comes up, were the results in RACE-2 due to the fact that strict rate control was not actually achieved in all the patients in that cohort. And so to analyze that, the investigators from the RACE2 trial went back, and in a paper in this issue of JACC, have taken those patients and looked at the patients who obtained strict rate control, those patients who were in the strict rate control group but in whom a strict rate control was not acquired, and patients who were in the lenient group. And what they observed was, in fact, that this did not make any difference in their findings. There still was no advantage to strict rate control over and above lenient rate control in these patients with permanent atrial fibrillation. Now, I think for many of us, we will regard this as a boon, since obtaining strict rate control in many of our patients requires multiple medications and often side effects. But at least for the moment, the data would suggest that it's not necessary to really acquire very, very strict rate control in patients with permanent atrial fibrillation. I found the February 19th issue of JACC particularly interesting. It turned out that angina really was not an important prognostic factor in patients with coronary artery disease. On the other hand, mental stress was shown to be an important provoker of myocardial ischemia. And of course, the data regarding the fact that strict rate control in patients with permanent atrial fibrillation was not absolutely necessary was somewhat reassuring to those of us who have trouble producing this in many of our patients. I hope you enjoy reading these manuscripts.